All right. So today again, human trafficking part two by Kate. And as you recall, she was here just a couple of weeks ago, and some of the things to kind of look for in the medical field. And again, remember, there is an in-person event. This is mostly kind of pointed towards our county sheriffs, jail administrators, kind of correctional leadership and other staff in the jail. It's coming up on May 7th. So it should be a good time for people to learn a lot. We're hoping that we get a lot of people from the jail. So please let your jails know that there's opportunity to come to this. Going to be in Waite Park. We have a lot of pretty interesting talks coming up. And actually, Claire Drom from Centricare is going to be coming next week. I'll be talking the week after about ADH treatment in patients with SUD, which is something I deal with every single week. And I think one of the great talks coming up, Elizabeth Salisbury is from Wisconsin in Madison, and she gave one of the plenary talks at ASAM last week in Dallas, and she agreed to give a longer version of her chat to us on May 8th. And she is an amazing speaker, just a great, fun person to have on. So lots of good things coming up. And again, and after that, of course, Charlie's coming back to finish his little talk. He's about the fight against fentanyl and meth. So we just have one great talk after the next. So next slide. Remember, there's free CME. Everybody knows that. Make sure you fill that out. Again, Kate loves to talk to pictures and not black boxes. So please feel free to turn on your video. We will not make fun of you if your video is on most of the time. So please feel free to turn that on. Again, if you have questions, please feel free to reach out to us. Erin is probably the first quick thing to try. She's probably a little more available at times. But otherwise, give my phone a call, 320-630-2507. Also, always happy to answer some questions. We get some great questions from these phone calls. Next slide. And again, online, if you want to look at the Center for Opioid Resources, lots of things there. Don't reinvent the wheel. There's protocols of every type. I'm actually working on changing some of the protocols here at Centricare for our ER for a grant that we have coming up. So I'm going to put in some different things for the macro dosing, which when they're done, although again, there's many right ways to do this, I will be happy to share those when they're through. Next slide. So now we're to Kate, and we will let her introduce herself. Most of you probably already know her from a couple of weeks ago, and that's why you're back. We'll let her share her slides and introduce herself again, just for those of you who maybe did not meet her. Thanks again, Kate, for coming.
Yeah, thank you guys for having me. And I have minimized all the faces so that I have my full screen up because I don't have two monitors because that's just more to have not work for me. So I'm Kate LePage. I'm the East Central Safe Harbor Regional Navigator. I cover 11 counties in my region, and I'm actually developing another 9 counties in Northwest Minnesota right now as well. I'm one of 9, soon to be 10 regional navigators in the state once we get our Northwest individual hired. So if I don't cover your area, please reach out if you would like to connect with your local navigator. I'm happy to make those warm handoffs as well. Last time we talked more of an introduction into trafficking. I know that there may be some people on today that weren't on in the last one. So the first 2 slides might be repeats for those, but I'm going to go through those really quickly. I just want to make sure that we're all on the same understanding of what trafficking is as we move into today's presentation. So I'm just going to quickly give those definitions again. And then just do my quick housekeeping as well. Again, this is something that I do before every presentation, just in case somebody wasn't on 2 weeks ago when we covered this. But a little content warning, especially virtually, I can't gauge very well people's reactions to things. I'm not going to go in depth into anything too traumatic, although I never know what people's own experiences are in a training. So just content warning that we're going to talk about trauma. Again, not in a graphic manner, but it can be triggering. So please take care of yourself and just be aware that we will talk about trauma today. Please pay attention to your preconceived ideas about what trafficking is. We're going to talk about how it doesn't happen in a bubble, and talk about a lot of the co-occurring trauma or addictions that take place during or prior to victimization. And so just be aware of what your own mentality is around what you believe trafficking to be, and just make sure that you're aware of that. So as we go into the training today, you're open-minded to what it really is looking like in Minnesota. Our language adjustments, again, if you are looking into statutes at all, if you're mandated reporters and you're paying attention to those legal language components, you will see prostitution still used in statute language. Sorry, I had someone about to come into the office. However, those have really negative connotations that come along with it. So really referring in our practice and when we're sharing this conversation with others to use some terms that really promote a better narrative, right? Victim, survivor, or someone that is experiencing exploitation. John, again, that can humanize the act of purchasing. And when we're purchasing sex, we create power and control. So what we're really doing is we're engaging in a sexual assault experience. So shifting that to buyer and exploiter just holds a little bit more accountability to those individuals purchasing. Pimp, especially young individuals, have a mentality around what a pimp is, and it leaves them more vulnerable to people that don't fit that image. So trafficker or exploiter. And then child pornography is also used in statutory language, and we have to talk about that when we're talking about exploitation and trafficking. However, it also has really a negative narrative that comes along with it. It's really child sexual abuse material. And so we're trying to shift that in our day-to-day language as well. And then continued education. We're going to talk a little bit more in depthly today, but everybody has different systems. So if you're wanting to know how to implement these practices into your own system, please reach out. If it's not myself, I can connect you with another navigator that's in your area to really dive into conversations on in your practice with the patients that you're seeing. How can we be addressing this issue? So again, here's my quick definition before we get into today's presentation, just again, to make sure that we're all on the same page with what this is that we're talking about. So commercial sexual exploitation is kind of this large umbrella, and a lot of things fall under it. Commercial sexual exploitation is the exchange of something of value or the promise of something of value for a sexual act. So that thing of value can be really anything that's perceived to be of value. It can be food, it can be clothing. We see a lot of transportation, especially in rural Minnesota where there's not a lot of transportation, housing. It can be money. It can also be things that are non-tangible, like status in a community. We see that within our gang communities quite a bit. So anything of value or the promise of something of value for a sexual act is commercial sexual exploitation. And we do have a purchasing of sex, so we do have a criminal act. In Minnesota, it becomes sex trafficking when you have the act of a third party, not the purchaser or the victim, facilitating or profiting from a commercial sex act. So that means we need to see a third party involved, whether they're benefiting completely or partially or knowingly participating in that commercial sex act. Then we have sex trafficking. For mandated reporting purposes, there are some changes coming to mandated reporting in July of 2024 and July of 2025. So just keep in mind that there's some changes coming with mandated reporting statutes in Minnesota. As of today, it is a mandated report if you suspect a minor is being trafficked. So if there is that third person knowingly participating or profiting in any way of that commercial act. So just keeping that in mind for your mandated reporting purposes. And if you're ever curious about a situation and you would like to know if it is a mandated report, because it can be a little confusing and it falls outside the scope of normal mandated reporting, please know you can always contact your regional navigator and we'll walk you through the situation that you're identifying. And you don't need to give any patient information to do that. You can give the concerns that you have in a general manner. So when we look at how this is interacting with victims, we really need to look at how the grooming and recruitment is taking place. So really offenders are looking for vulnerabilities in individuals. And this can look a number of ways. There's no exhausted list. Some of the things we see a lot is history with trauma, unstable home life, substance use and abuse, various disabilities, in our minority population. I'm not going to go in depth into this too much, but we do have this grooming process because, like some of you may remember from the other or previous training, we really don't have a lot of situations of stranger abduction. We really do see this grooming and relationship process formed, or situations of familial trafficking. So whether that's a friendship, a romantic relationship, an employer, we do have this grooming process that's taking place. Not that abductions and kidnappings can't happen. However, in our most recent OJP report, we still had 0 cases investigated in Minnesota of a stranger trafficking situation. So keeping this in mind, that we can be identifying concerns and red flags of trafficking along the way. And ideally, we can be working in a preventative manner too when we remember that there's that grooming and recruitment component. So again, just some things to keep in mind when we're looking at this grooming component. I'm not going to go too far in depth. I just want to make sure that we're all kind of remembering that we do have these opportunities to play this harm reduction model and intersect sometimes prior to abuse as well. So we have family where it's embedded in family systems and it can be really generational. We have the sexual abuse material, or CSAM, that's used to extort, blackmail for revenge, or used to facilitate the trafficking and exploitation as well. And then we have the grooming through unhealthy and abusive relationships. And that can look a number of ways. Again, it can look like romantic relationships, friendships, employer relationships, but we still have that kind of same track that we see. And I don't know how to get rid of this little thing at the, I think I got it. Oh, perfect. So populations experiencing higher levels of exploitation and trafficking. We have our minority communities. Our indigenous populations have the highest rate of victimization for our, based on race, and that's followed by our Black or African American communities as well. Our trans and gender diverse individuals are victimized at a much higher rate. About 5.5% of youth that identified as trans or gender diverse said, yes, we've experienced exploitation, compared to about 1.4% of the general population, or our cisgender boys and girls. People with seen and unseen disabilities. So again, we know that physical and mental health disabilities can cause additional vulnerabilities that can be taken advantage of. Unaccompanied minors or foreign-born individuals as well have additional vulnerabilities that can be exploited. Also, I see a higher risk for our minor parenting youth as well. So just keeping in mind that those different things can increase the chance that somebody would target and groom that individual. Resource deprived communities, that's why we see, I know it was a question last time as well that we touched on briefly, that we actually have higher rates of disclosure from our rural communities, our outstate communities, than we do from our metro-based areas. Systems involved individuals, and then those with intersecting identities experience higher rates of exploitation. So what we're going to focus on today is more that human trafficking really doesn't happen in a vacuum. We see that individuals that are experiencing human trafficking are usually experiencing or have experienced multiple forms of victimization, and human trafficking is just one of those. And sometimes for our patients or clients that we come into contact with, it's not the most concerning thing that they're dealing with at that time. So sometimes when we try to target one specific type of victimization, we actually have people fall through the cracks because that's not what they're identifying as their biggest issue. So we really want to open our eyes and our minds to the fact that we're looking for all these different forms of victimization that are intersecting as well. So we're going to dive into a couple a little bit more fully, but these are just some of the co-occurring traumas that we see on a consistent basis. So when we think about the fact that most trafficking situations are relationships or familial, we have to understand that just naturally, we also have situations involving intimate partner violence or domestic violence, as well as child abuse. So already, as we're looking for signs of those types of trauma, we can be keeping in the back of our mind that there might also be trafficking that's occurring as well. Naturally, individuals that are experiencing trafficking are also experiencing sexual assault. For those of you that were on our last call, I played that video where individuals had come into a medical center seeking assistance and talked about how our medical professionals can be a really important role of getting out of the life. And what I find and what I train my staff on is a stages of change model. And I don't have time to get into the stages of change model on today's call, but if anybody would like to learn a little bit more about it, if you're unfamiliar, please reach out to me in an email and I'm happy to send information on it. But usually when somebody gets to this contemplation stage of leaving, it's because there's been a significant event. And we see that a lot with domestic violence as well. So somebody might come in for a sexual assault SANE exam because even though we would identify they experience sexual assault on a daily basis when it comes to trafficking, the sexual assault that they've identified with was a significant triggering harmful experience that matches what sexual assault looks like for them. So keeping in mind that you may have victims of trafficking and exploitation coming in for SANE exams, and if they are, that's usually an opportune time to offer services because it usually pushes people into this contemplation stage of maybe starting to realize that they're in a situation that's harmful to them. Physical assault or injuries, again, we see that not only with our connection to adverse childhood experiences, and I'm going to talk a little bit more about that in a minute, we also have situations of physical assault or injuries stemming from purchasing. So our buyers are causing physical injuries as well as traffickers can too. Unstable housing. So when I'm talking to youth in particular, I'm talking to them about red flags to look for and vulnerabilities. And I can't remember if I shared it a couple weeks ago or not, but one of the grooming tactics that we're seeing used more and more by traffickers is providing basic necessities. So it makes it really, really tough for individuals to leave these relationships. Substance abuse is very significant. About 85% of those that are being trafficked are also using substances while being trafficked. It's used as a tool to recruit and groom. It's also used as a coping tool during the victimization. Community-based adverse experiences. I think we talk a lot about like ACEs, but we don't talk about the community-based experiences as well. But that is, additional impacts, especially to our minority communities. Online harassment and abuse, forced criminality. Again, we see that a lot. And in particular, we see it a decent amount when it comes to drug-related offenses. And then systems involvement. So when we look at intersections of child abuse and sex trafficking, some of our Minnesota numbers and these numbers are a little bit dated, but the newest ones that came out were pretty consistent. I just don't have them. But they were saying that family-based sex trafficking was the most commonly reported type of sex trafficking in Minnesota. It's still a little over 60% of our reported cases are familial-based. So if you're identifying a youth that you have concerns about, really keep that in the forefront when you're talking about safe ways to offer services or ask further questions, that we do still have a significant number of cases stemming from that family home life. in addition, when we talk about adult victims, a lot of their victimization may have started as a child as well. 8.1% of youth who self-identified as having experienced exploitation and trafficking in Minnesota, or youth that were in foster care reported at 8.1%. Sorry, I said that backwards a little bit. That they've experienced exploitation and trafficking, and that compares to 1.4% of the general population. So if someone's in foster care, they're at significantly higher risk of having or experiencing exploitation and trafficking. So this just looks at ACEs a little bit further. This was a study done in Florida, looking at how ACE is associated with increased risk of exploitation and trafficking. So if an individual has 6 or more ACEs, their risk of that victimization goes up pretty significantly. Girls had a little bit more of an increased risk with emotional abuse or physical abuse. Boys with a history of emotional and sexual abuse experienced significantly higher rates of trafficking. And for whatever reason, I can't pull up my notes, and I don't really use a lot of notes, but when I have statistic points, I like to make sure I'm saying the right number. But it's about 8.4% or increased risk. So about 8% increased risk of exploitation and trafficking if boys have experienced that sexual and emotional abuse in the home. And because I can't see the statistic, I can send that to Katie to send out to everyone as well at the end so that you have the correct number, just because I love data. I'm a little bit of a data nerd, so I like to make sure I'm representing it correctly. So then when we would look at intersections of intimate partner violence and sex trafficking, we really can compare our power and control wheels. And we do see that they're very common between intimate partner violence and sex trafficking. There's maybe a few extra components to the sex trafficking, but most of the time we do have situations of IPV with trafficking. We have coercion and threats, we have intimidation, emotional abuse, the use of isolation from everybody. There's one video that I don't have time to show, but it's of a trafficker, and he talks about all of the tools he used to manipulate and isolate his victims. So he never used any physical force or abuse to traffic individuals out of his business. He really used isolation with a number of hours worked, times that people were working, really paying attention to people's need for the job, so that they couldn't leave. So he would wait till they had just purchased a new car or gotten into a new apartment, and they were really dependent on him and his business. And so that's when he would begin some of that exploitation. So really looking at how they're using those manipulation and isolation tools. Denying, blaming, minimizing, using sexual abuse and physical abuse, privilege, and then economic abuse. So really looking at what their basic needs are and making sure that the victim is dependent on them for those basic needs. So again, so many similarities between our power and control wheels. And these traffickers, exploiters, abusers are really good at utilizing Maslow's hierarchy of needs to identify where they need to create the manipulation and grooming based on where someone sits in that Maslow hierarchy of needs. I will say that sometimes it's we expect the trafficker to be the really dangerous and abusive person. I have worked with some survivor consultants, and their trafficker was more like a parental figure to them, really was caretaking and nurturing, would tuck them into bed every night. And they really saw that person as their protector from their buyers, really not connecting in their brain that their trafficker was setting up these buyers for them, but seeing them as the person that kept them safe because it was actually their buyers that were abusive and causing physical harm. So really keeping in mind how that manipulation and mind control plays a big role in how people see their abusers. So again, just simplified down a little bit. And we see both of these happening within sex trafficking. We have a lot of situations where people are being trafficked by their significant other, whether that's a marriage or not, and they have children with their abusers as well. So we see all of these things impacting someone's ability to leave. And we can also look at all of these things as red flags and signs of an abusive relationship that may also involve sex trafficking. So again, I just wanted to share this. I know we talked about it a little bit last time, but a lot of us, and again, these are those preconceived ideas. We want to believe that sexual violence in general is taking place by strangers. I think it makes ourselves and our communities, our society feel a little safer because then you can prevent it. But really, what we see time and time again and consistently is that these are relationships that we're having to be aware of, which also means that when you have a patient come in, it's being aware of who their potential perpetrator is that might be with them. When we have rings of trafficking, when we have a trafficker with multiple victims, you may have a situation where two victims come in together. It's still not safe for your patient to talk openly about their victimization if they're with somebody that's also being trafficked, right? Because you don't know if that person is going to snitch on them or things like that. So just keeping in mind that the ages of traffickers are getting younger and younger. So we're not necessarily able to look for that large age gap. And we can't always look for the typical domestic violence relationship either. We want to really identify the family dynamics and the dynamics of the people coming in together and just create policies where a lot of the time when we identify a victim, we want to allow them to keep their safe person that they've brought with them next to them when they're having hard conversations. But in particular with trafficking, just because we know that these relationships can be so layered and confusing, that may not be safe. So then intersections of substance use and trafficking. So of course, this group is really geared towards substance use. We know that, and I'll say almost every single individual that I have worked with has had some level of use. I know we're moving away from marijuana being illegal, but when we think of minors in particular, I see a lot of that use still going on as well. And even as it becomes legal, minors aren't going to necessarily be able to get it legally. So there's always that concern of it being laced with things too. We're continuing to see overdoses of fentanyl and marijuana as well. But again, 85% of trafficking victims were using substances while being victimized. I think any numbers that are related to victimization, in particular sexual victimization, and even more so sex trafficking because it's so hidden, those are always lowball numbers. We see a lot of forced criminality when it comes to trafficking, where we have people dealing drugs as well, so coming in contact with substances that way too. 16% of youth in Minnesota that reported being treated for substance use and abuse reported also experiencing a form of commercial sexual exploitation. So 16% of youth compared to the general population of 1.4%. So that's even more significant than youth that are in placement in foster care. So again, huge correlations. And if they're experiencing that as minors, as they move into adulthood, it's still as significant for our adults as it is for our minors. There was a study done by Carolyn Palmer at MDH looking at, in Minnesota, how substances were most often used. So we saw that youth, at least in Minnesota, were more likely to say that they were using alcohol, marijuana, methamphetamine, tobacco, and opioids were the top substances that they reported using. Again, I think that it's a pretty scary world right now with fentanyl, and it's being laced into so many things that I think that more people are using fentanyl than they probably know. So in the same study, if a service recipient either disclosed sex trafficking or exploitation, for those of you that can't read because it's pretty small, or you suspected it was happening, what types of control involving substances did they describe a trafficker or someone else using? So they said that substances were used to promote not if they didn't want to allow safe sex practices. So if somebody wanted to engage in a sexual activity that was not using those safe sex practices, like a condom, they were more likely to be controlled through substances. Withholding substances for manipulation practices was pretty significant. Using substances to enforce control over their victims was also brought up quite a bit. And I'm happy to send this study out to anybody that would like to learn a little bit more about what they found with this study. Threats to inform family. So a way to control was, I'll tell your family you're using drugs. If someone was a young age, we have that forced criminality component with the drug use and connection to drugs as well. One thing that we saw a decent amount was a debt repayment for substances. So we saw, and I've heard this from a lot of youth too, or victims too, of their exploiter or trafficker was also their drug dealer. So in order to get their substances, they were repaying debt through trafficking means as well. And then threats to law enforcement. So again, a lot of individuals that are being trafficked identify that they're doing something illegal by engaging in quote unquote prostitution, which is another reason why that term is so harmful. So on top of being worried they're going to get in trouble for the trafficking or the quote unquote prostitution, they're now also worried that they're going to get in trouble with law enforcement for the use of substances. So it may prevent them from coming in to receive care as well. Some other intersections to be aware of with healthcare is victims who came into contact with healthcare professionals. I think it's just a good idea to remember that, when I was doing some protocol work with one hospital, we were talking about who should be involved in the new algorithm within Epic and who should that be rolled out to. And immediately we always think of the emergency department, which makes sense, right? We had the highest percentage coming out of the emergency room. However, we did see these other areas impacted as well. Primary care, OB/GYN, again, we talked about those relationships. And so we do have a lot of people that are seeking medical care for that as well, or that are having children with their exploiters, maybe even their buyers, or their traffickers. Again, I have a decent number of minor parenting youth as well. The dentist, that one gets left out a lot in making sure that people within that field are also aware of exploitation and trafficking. Pediatricians and others. So again, this is really, it can be so broad. And as people leave the life, I see this a lot with homeless populations as well. Once they're in a stable, healthy, safe environment, they start to have a lot of medical needs that come to the surface that have kind of been suppressed as they've been in survival mode. So there may be other more, what's the word I'm looking for? Selective care that would also really benefit from the information. So different things that are health consequences of human trafficking. Again, we have physical abuse. We see a significant amount of traumatic brain injury taking place, but also chronic pain and traumatic acute injury as well. Again, we tend to see that buyers are purchasing risky sexual acts, quote unquote, the porn star experience, acts that are related to, sexual violence. And so we do have situations where an abnormal or a more, in a victim's mind, severe sexual assault or purchase happens that can cause injury that they're coming in and seeking assistance for. Sexual abuse. So some of the things that we see are sexually transmitted infections and pregnancies, emotional abuse, post-traumatic stress disorder, suicide ideation. We see a lot of self-harming behavior with victims of exploitation and trafficking. So again, if you're seeing concerns of that, that can be a red flag to ask some more questions about as well. And if you're wanting any of these resources and pictures that I have, for you to send anything out from today's training as well. Poor living conditions. So you may see people coming in that are very malnourished or dehydrated. I come into contact with individuals through law enforcement on a fairly regular basis that maybe haven't eaten in days or haven't slept in days. So really ask if you have some concerns about exploitation and trafficking, asking some of those questions as well to get a better scope of what their living condition is and what their nourishment needs are. Substance use and overdose, as well as death. So other things that, especially when we look at substance use and treating patients that are experiencing substance use, you're also probably experiencing people that are involved in situations of unstable housing. So 64% of survivor respondents to Polaris, which is a national hotline that does a lot of studies and research based off their hotline, not Polaris like the snowmobile, but their survey reported that 64% of survivors reported being homeless or experiencing unstable housing at the time they were recruited. So again, that correlates really strongly with the data that came from a 6-year analysis of traffickers that found that more and more traffickers are using basic necessities to groom and recruit. So there's high incidence of accessing homeless shelters to exploit or recruit or identify vulnerable parties. We have a lot of people engaged in survival sex, especially in rural Minnesota, where there aren't any shelters or 24/7 businesses where people can loiter. It becomes a survival, life or death in the wintertime, in particular for Minnesotans that are homeless. So we see a lot of survival sex in order to couch hop and things like that. Access can be before recruitment or while they're trying to leave their situation. So that's another important thing to remember is due to forced criminality, we have a lot of people that can't leave their living situation. They lived with their trafficker and they may have evictions on their record or felonies on their record. And so if they leave their trafficker or exploiter, they'll be homeless and more vulnerable to the next victimization as well. Instability, and then food insecurity as well. So then there's these survival barriers to disclosure. So I think sometimes we come in as well-meaning professionals and we're seeing all the signs and we're not understanding why somebody still isn't disclosing as we're bringing up their concerns. There's a lot of shame and embarrassment, guilt, but also mistrust of the system. So in the brainwashing, the manipulation of an exploiter or abuser, they're often telling victims, survivors that they can't trust the system, they can't trust professionals, they sure can't trust law enforcement. And so if as a medical professional, you're offering to bring law enforcement in, or you just call law enforcement because you have these concerns, or advocacy because you have these concerns without the victim's consent, it kind of reinforces that mistrust. Trauma coercive bonds or trauma coercive attachment, sometimes referred to as Stockholm syndrome or trauma bonds. So really on a chemical level, bonding with their abusers as well. It's a hard bond to break. Language access, it's really hard to access translator services at times that are that feel trauma informed and that feel trusting of the victim. I've had situations where I've been in talking with schools, and because a lot of the translators are virtual and the victim survivor can't physically see them, there's a distrust of who else is listening into the call on the other end, because victims of exploitation and trafficking are extremely hypervigilant. I moved away from using the word paranoid because they usually have reason. Their phones are tracked, their vehicles are tracked. They're always wondering how their trafficker knows things. And so if they can't physically see that translator, there is potential for that hypervigilance and that mistrust of who else is on the other line. Previous discrimination. So I know it was talked about in the video that I showed last time as well, that you may have the best response possible for this victim survivor, but they had one negative experience with a medical professional, or one negative experience with an advocate, or one negative experience with a law enforcement officer. And there's this previous discrimination, and they just, they don't trust anyone in that field anymore. So keeping in mind that it may have absolutely nothing to do with you, but a previous experience that they did have. And a lot of the times the people I'm working with don't see themselves as victims of crime. I've 13-year-olds that are in their mind in relationships with 30-some-year-olds, and they don't see any issue with that. It's a healthy relationship in their eyes. It's a choice that they've made for survival in their eyes. It's a viable lifestyle option. And so they're really not seeing themselves as victims. So keeping in mind some of those barriers, also fear of withdrawal, assumptions of why they're living the life that they're living, being outed. So a lot of people, I think especially minors that are involved in exploitation and trafficking, are not necessarily gone from their normal mainstream world. And so especially I think our LGBTQ plus community and our cisgender boys, especially our cisgender boys that are not, they don't associate as being gay, have a really tough time with fear of being outed as well. Fear of incarceration or what their exploiter will do. Even if their trafficker exploiter is not typically physically abusive, there are threats of abuse to them or their family members, or their children if they have children with those abusers. Losing their livelihood. A lot of people that leave a trafficking situation will enter into a two-party commercial sexual exploitation situation because they know how much money they can make if they sell themselves. And if they move away from their trafficker, then they get to keep all of that money. So they're still experiencing victimization, but they don't know another way to create livelihood. Returning to an abusive placement. So again, we see this a lot with minors. Minors that are targeted, like we saw with the ACEs study, are more likely to be experiencing abuse in the home or witnessing abuse in the home. And so sometimes it feels better to experience victimization over on this side with this person that's not a family member than it is to experience it in the home. And they often don't want to get their exploiter in trouble. So I was just at a conference in San Diego last week, and one of the scenarios that we talked about, one of the cases that we talked about was a young girl that was targeted and kind of held by multiple men at a college. And one of the men climbed into bed with her and really scared her. And so she went over to one of the roommates, and he was the one that got her out of there and brought her back to her parents' house. And even though he had already posted ads for her online, she saw him as her protector. And so when it came down to charging individuals, she was only willing to be a witness in court against one of the individuals and not both of them. So only one of the individuals ended up getting criminal charges. So there's this, especially when someone is perceived to be kind of a savior to them in some aspect, even if they're part of the perpetration, there's this really strong disconnect in charging or wanting accountability held for that individual. And that gets even more complicated when we look at situations involving familial trafficking. And a lot of times people think if they make a report, that person's going to get in trouble and they won't have any control over it. And that does happen sometimes. So making sure that you have some advocacy there to really talk to them about what could happen if they make a report, and to advocate for them if they're not ready to press charges. So then referring to services best practices, really we want to assess safety. Is the patient alone? Is someone listening to their appointment via electronic devices? If you're doing a virtual appointment, is there someone else in the room? There's ways that we talk about, in court appearances as well of, are patients constantly like eyes darting somewhere else in the room? Can you see a shadow? Is there any background noise? So really trying to pay attention to those things. And if you have concerns, always finding a reason to bring them in person to have those conversations, just because, again, we never know who's listening in on those appointments or connected to electronic devices. Again, that conference I was at, I went to a pretty interesting training on online stalking and just some of the data apps that can go on, that can be downloaded on people's phones now, where all the conversations are recorded. So even when someone's not in the room, if there is concern for that control aspect, making sure they come in because their devices can be tracked. It's really easy to get these bags that when you put your phone in, it stops recording and being able to be tracked and things like that. So if you're finding that you're coming into contact with a lot of victims that don't feel safe talking openly, you could look at getting some of those for your office just for the sake of during the meeting. Would you like to put your phone in here while we talk? But just kind of putting that into your general practice that we really never know who those potential abusers are. And with the current technology, we honestly really never know if they're listening in on someone's phone. Victim survivors know best what's safe for them. So I think a lot of the time we want to really push people to...
For the Fed, here's NPR's Raphael Nunn. It continues to surprise, and not in a good way. Consumer...
Sorry. So really know what's best for them. We want to often provide resources and have people take things. I always ask them, is it, would you like to take these resources? Would it be better if I give you a call, or is it safe for me to send you a text at some time? So I really try and offer them options for connecting to services so that they don't feel like, well, if I don't feel like it's safe to take this resource, I can't access the resource. So making sure we give them options for resources, but also ways to take that information. I know that I myself, as well as some of my peers in law enforcement or my partners in law enforcement, will say like, hey, put my name as whatever you wanted in your phone, so it doesn't highlight things like that. And I try and be really careful when I answer phone number or phone calls and things too, that I don't advertise who I am right away, just in case it's someone calling it back that's not my actual client. I should say, for assessing safety, one thing that's come up in protocol development or with some hospitals is some changes to the Privacy Care Act, and with all doctors' notes going on to my charts and things like that. I guess there's a way that you can check a box to not, or you may be able to check a box to not have those notes put on. So if you're ever having notes where there's been services offered or concerns of victimization offered, please don't put that on my chart. In a lot of these abusive situations, whether it's trafficking or domestic violence or familial abuse, those abusers have access to those platforms and their login information. So just being really careful what we put into our patient care notes as well. Offer services broadly. If services are declined, offer resources to take or safety planning. One way I offer services is, again, a lot of times people don't identify as being a victim. So I offer a range of resources. Do you need connection to food support, emergency shelter, transportation? Was it easy to get to this appointment? In order to get you to your next appointment, do you need help with transportation? Oh, great. Let me connect you to this person. And you can still connect with victim advocacy, where we can be providing some of those basic needs so that someone doesn't have to be exploited for that basic need. And it allows us to start building rapport with somebody and without them having to identify as a victim. Do not condemn the identified perpetrator. So again, there's often a really strong bond between people. So just being really careful that we mimic the language that our patients or clients are using around those perceived perpetrators. Offer autonomy and choice whenever possible, even from where they sit in the room. I think that medical professionals are getting really, really good at that. There's multiple places to sit whenever I go into a medical office or patient room. And so I think that that's really helpful, is giving them some even small autonomy to sit where they want and things like that. Avoid probing for details and answers around victimization. So, we don't need those details. If you have concerns of exploitation and trafficking, you can always offer services, especially those broad services and the range of services. So we don't want to force them into making disclosures, especially minors, because if we have a minor that we force into a disclosure, now we're forced into a mandated report as well. And so we want to make sure that we're always keeping their needs in mind as well. So there's some different screening tools specifically for healthcare. So the Department of Health and Human Services, and then the National Human Trafficking Resource Center has some that really walk you through considering red flags, assessing patients, assess potential danger, and then making those referrals. Again, I'm happy to send out any resources specifically for that. Although what I would recommend is, if you're wanting to embed some screening tools for your own healthcare system, let's have conversations about what your healthcare system looks like and have that on an individual basis to make sure we're getting you the best tools possible for how you want to implement them, or what you're hoping to gain by implementing them, as well as what your structure looks like and what your local resources are. So I know there was a conversation about more conversations on how to connect with people that you think may be experiencing exploitation or trafficking. It's hard to have those trainings virtually for me, because I want to have some dialogue around that. I think it helps to role play some of that. And I think those are some really great trainings to have in person with your team, or with your team specifically, so that we can have some scenarios developed for the line of service that you're in. But really, what I always say is the best thing to do is be authentic. A lot of these individuals that have experienced exploitation and trafficking are really, really good at assessing if people are being authentic, because it's a survival tactic. They need to be able to know what someone is thinking and wants to hear from them when they walk into a room. So if they don't know what a buyer wants from them, they're more likely to experience physical abuse as well, or escalated abuse. And so they get really good at assessing the room and kind of manipulating the situation. And I don't mean that in a negative way. So be authentic, show that you care, ask open-ended questions that allow them the opportunity to explain what's going on. Offer services, but again, offer them broadly. We don't want to just focus on their victimization, because like I said, it doesn't happen in a vacuum. And so although you might identify their trafficking as their biggest concern, if you are only focused on that, and you don't pay attention to the fact that they haven't eaten in a couple days because your main focus is the trafficking, then they're going to feel like you're not listening or caring about what their needs are. So again, just be really broad with it. Make sure that we're asking what types of services they're wanting. And I always give examples, like I did in the PowerPoint as well. And I'm happy to share out those PowerPoints. What I've done in the past for some medical providers is I've provided little quotes of things to say or that you could say. There's also what's called the Mighty tool that was developed by the Minnesota Department of Health. And it's a tool as you're assessing red flags on ways that you can ask questions and then types of resources that you can offer based on responses. So we can provide some quotes to get you started, but I really suggest taking those quotes and making them your own, because if you don't sound authentic, people aren't going to want to be honest. SOAR has some pretty good resources as well. They're designed to educate healthcare providers, social workers, and then public health professionals as well. I should say as behavioral health professionals too. So SOAR is a really great resource. They have trainings, they have different resources for handouts. I always suggest getting your handouts locally because a lot of these programs like SOAR are nationwide, and our statewide definition doesn't even match the federal definition. So just making sure that the resources are local and the information is local is helpful, but they do have some really great training as well. And I have just a couple minutes for questions. I know we ran right to 1:15 last time.
Yeah, and if you want to maybe stop sharing your screen, and if people have questions, I know I have a couple, but if somebody wants to unmute, that'd be great. Or chat something in. You know, one of the things when you were talking about family involvement in trafficking, is it more often a brother or a parent, or, you know, who's typically the person that's doing the trafficking?
Every situation can look different. You know, what I find is often, what a lot of the data suggests is that often it's actually a mother that's involved. And a lot of the time it's to meet a basic need, including substance needs. So the parent might be struggling with their own substance abuse issues where they're offering someone sex with their child in exchange for substances. We see this happening with housing supports in order to pay bills for housing and things like that as well.
You know, such a majority of the patients that I see in the addiction clinic here are fentanyl based, and more than half women, I would say. Is there any data on like what percentage of patients that use fentanyl for any period of time have been involved in trafficking? I mean, just to give us an idea.
Oh, sorry. No, I didn't mean to cut you off. So that study that I showed that went into substances, it does touch on fentanyl. Fentanyl was not one of the top 5, so it's not listed on my PowerPoint, but I'm happy to send out that information. I don't know what the statistic was off the top of my head, but what my concern is, and I'm sure you guys are seeing this as well, is so many people don't even know they're addicted to fentanyl until later on because it's being laced in so much. So I'm kind of just looping fentanyl into most of my conversations around substance, just because it's being laced in everything, even including weed. And I know that's just increased in popularity over the last couple of years. I was at a narcotics conference 3 years ago, and I asked some people in the metro because I had been seeing up north a lot of people ODing from fentanyl that was in their weed. And I had asked people out of the metro, I said, are you guys seeing this as well? Because it had stemmed from some reservation communities at first. And they had not. 6 months later, and they had. So this is continuing to increase. But I will get you the statistic on what they were self-identifying as having used fentanyl.
Okay. Yeah, it's funny because even last week I had somebody say, I've done everything but have sex with people to get fentanyl. And I'm not quite sure what that meant and whether or not she was just trying to avoid the rest of the conversation, but it sure seemed concerning that something was going on. So,
Well,
you know, Go ahead.
I was just going to say, I think what's really important too is it's kind of like we now have to change how we ask about drug use to say, do you use drugs? No. Okay. Do you smoke weed? Yes. And probably something similar with this as well of if they didn't have, you know, penis to vagina sex or, if it was a blowjob or something like that, are they constituting that as a sexual act? And so again, I think sometimes it's asking some more questions as well, and those can be really uncomfortable conversations.
Yeah. When you come across these types of things, like for instance, in a small community, are they typically trafficking these young ladies to people outside of their community? If it's a small community, are they bringing people in so that they don't draw attention?
So I'm just going to quickly say girls and boys, and then gender nonconforming, because our boys and girls are about victimized cisgender boys and girls at about the same rate. And so I think that we sometimes forget about boys being victims too, because they exhibit trauma responses in a little bit of a different way typically than girls. So just really quickly on that. But so what we find is that buyers are traveling between 30 and 60 miles per transaction to create more anonymity for themselves, especially in small communities. I used to live in Becker, and I would say there's 2 hotels. So if I had seen my husband parked at any of them when we lived 2 blocks away, that would be a red flag. Like, why do you have to be there? So yeah, we see that people are traveling to purchase. We also know that victims can also be transient. So we might have victims brought to areas that there's maybe a higher demand for purchasing. And we also have buyers traveling. So we can have both components traveling. You also have word of mouth, and especially when it's 2-party. And not a third-party interaction. You might have regular buyers or people that are their dealers, and they might live in the same area. Predominantly, our buyers are middle-aged, married, middle-class men. So we do have people that fall out of that. So we do have locals purchasing locals in a way. But yeah, the majority of people are commuting for that transaction.
Okay. Anybody else have any questions? I have one more, but I'm happy to pull back here if somebody has a question. All right. My last question is really now I'm gonna forget it. There you go. See, then it just went away. Yeah, I think I'm out of questions then. Anybody else that's got a question or anything else before we let Kate LePage go? I mean, obviously we're a little bit over, but everybody's kind of stuck around. So.
And I'm just putting my email in the chat as it had been requested. So if anybody wants to email me or think of questions later, or you want to get connected with your local navigator, please let me know. I'm happy, like I said, to make those warm handoffs or to have further conversations about implementing practices in your own clinic.
Yeah, well, perfect. Well, Kate, I mean, it's really, I think, very good for us to see this kind of stuff. I think often it's easy for us not to think about it when we're seeing patients with addiction. So it's just always important for us to keep our eyes and ears open and make sure that if somebody needs help, that we're getting that help for them. So thank you so much for all that information.
Thank you. And my last plug, if you don't mind, would just be if you guys have support groups for people experiencing substance use, and I don't know if that's something that any of your clinics host, but we can always do education to potential victims or users as well to make sure that we're either offering services or following a harm reduction approach to, hopefully preventing victimization as well.
Perfect. All right, everybody. Thanks, everybody, for coming this week. Again, next week we'll be up and at it again, so feel free to join us. And again, thanks so much, Kate, for spending your time with us and sharing such good information. So everybody have a great week.